Hi everybody, I just want to take a moment to thank you for partaking in the Novice Mentor program. It's going to kind of walk through. We're going to try to go week by week and kind of walk through what we're thinking as we go through the manual. So when you first start the first day, it's going to go over the Novice Mentor program in general, remind them that it's on a weekly basis. It's a 12-week program, and they're expected to have a consistent schedule that you guys will work out. As you walk through the manual, you'll see the first part we talk about is just trying to have them an algorithm, trying to have them start thinking through the process. And I'll go through this first one with you, and you can kind of read through it as I go. But the first question in general, this is for lower back, but in general, does the patient have symptoms distal to the buttock, or you do it for neck, is it below the shoulder, AC joint? If it's yes, then we go down. Is it centralized or repeated movements? Yes or no? If it's yes, then we think this is more of a directional preference, and what motion is it? Is it side glide, flexion, or extension? That's where it stops, and we continue our eval and go through the neural components of it. But let's say it's pain that went below the buttock, repeated motions didn't make any difference, then it might be the traction classification. Go back up, no pain that didn't go below the buttocks or the AC joint, but they have limited range of motion, yes. Then we go to limited range of motion, no, go to no limited range of motion. As we move on, look at limited range of motion. We said if it was yes, then we go down. Does it get better with active stabilization? So that means that when they activate, let's say they do forward flexion, then they activate their core stabilizers, and all of a sudden they can touch the ground, or they go into long sitting on the table, and now they can touch their toes. So if that happens, if it's stabilized, then it's yes. And if it gets better, then it's more of that's more of a stability, more of a strengthening problem. If it's no, it doesn't get any better, then we think it's more of a mobility issue. And then we say, how do we know if it's a muscle problem or a joint problem? We wind up doing, is there a decreased glide? If there's a decreased glide, that's more of a joint problem. No decreased glide, and then it's a more of a myofascial problem. If we went to this point, we get to resisted testing. So we went from here for stability. Let's learn more. Resisted testing. Is it strong? Strong and painful, yes. Then it's contractile. Treat it with some type of specific exercise, be it eccentric strengthening. We'll talk about more medical exercise training or MET. What if it's strong but it's not painful? Then that's normal. What if it was weak and painful? Yes. Then there's probably some type of partial muscle tear strain. Treat appropriately. If it's weak and painful, if it's not painful, but it's weak, it could be either a tear or just a deconditioned muscle. Treat appropriately. So that's where I kind of have them start to think about as they see these algorithms, to kind of think through that. So as we keep going on, the first week we'll talk more about that. We'll go into the lumbar week 1. We'll start talking about classifications. If you're not sure of them, there's always on the top, you can go to a link, which will bring you to low back classifications, clinical prediction, so it's directional preference, mobility, stability, that type of thing. Now we're going through the exam, and this part you can kind of use it as you like. You just have them look at each other, or you can look at what kind of stability the patient has, give them ideas, what to look for, those type of things. Give them pearls as you go along. This area for active range of motion for lumbar is you could teach them multiple different ways. You could have them, how do they find what that range of motion is? They do eyeball it. They use a tape measure. So that's Schober's test, which is the video right here. The basic is you're marking T11, T12, comparing it to S1, S2, and as they flex forward, that distance between your spots should increase, double for flexion and half for extension. It's another way to do it, or they could use a goniometer or bubble goniometer. I'm going to teach them looking for the quality of it. Again, do we do more repeated motions to see if that has any effect on centralization? We do the same thing for each part for lumbar. So tell them, these are some criteria. You don't have to use these, but this is the idea. How do I know it's normal? Is there enough a normal curve? Theoretically, can they touch your toes? Is the sacral angle more than 70? Is there a good weight shift? T12 goes behind the ankle. Those type of things. So you can do the same thing for each part of it. For extension, side bending. Again, for side bending, you're looking for, is a uniform curve. Do they have pain on the side you're side bending towards? Probably more joint or away, maybe more myofascial. Quadrant testing. as the video also shows you the different components of it, looking for the pain. Sitting exam, again, just if there are changes in this position, you can do some active range of motion, quadrants in this position. Slump, see if we can get, again, there's a video for that. The key to this part is make sure they clear all joints first. Have them go through the slump test, and you could read through what goes through it. Neural exam, same thing, is you want to be able to go through the neural exam, and you want to be able to look at it and have them be consistent with it. Okay, straight leg raise for consistency. A general straight leg raise without any kind of sensitizers, basic straight leg raise. Are they consistent when they do it? Again, myotomes choice, I do my myotomes in supine. If you'd rather teach them in sitting, that's okay, as long as we have a consistent, way of showing it. Myotomes, etc. Reflexes, the only one that might be a little different, patella tendon. The normal reflex, posterior tib, it's basically you tapping underneath the malleolus, or I do proximal dorsiflexion and tap on around the navicular part, and you'll get a little bit of a plantar flexion moment there. Review some of the red flags or discuss. Again, when they go prone, go through what you think. The more important part for here is definitely go through palpation and try to walk them through it. Usually young therapists have the biggest trouble with it. Again, to passive accessory testing, if you do central PAs, unilateral PAs, perfect time to teach it. If your philosophy doesn't necessarily utilize PAs, you could also do, for example, you could do AP sideline, AP testing, so shearing through that. And we can discuss it individually. Special tests, prone instability tests, one of the better ones. Here's the videos for lumbar extension test. AP translation is if you're not a Maitland PA, central PA person, this is where you can do some of your mobility testing through here. And again, time-wise, the videos are here for abdominal testing. Again, if it's appropriate for the patient. And then you can just review some of the special tests. Again, try to get through everything. So that's the end of week 1. Seems like a lot of stuff. What you do is go through, look through it, see the things you think they're having the most problem with. Thinking the whole process should be about an hour and a half.